Good, how are you?
Good, good. All right, great. So I'm hoping everyone can hear me. We'll just go ahead and get started, and I will share my screen. I will send out this slide set um, right after this presentation. I know that's what I said last week, but I'll do it this week. It's very similar, but we fleshed out a little bit more of our plans. So I hope everyone's having a good week. I know it's a challenging time for our healthcare system, and I hope that you had a chance to rest and recharge over the holiday. We'll go through our numbers. We'll talk about crisis standards, especially with our acute care hospitals, but I think something that really all of us in healthcare need to know about, and really everyone in the community at this point needs to know about what's going on in our healthcare system. Not good news, unfortunately, but that's the reality of where we're at. Then we'll move on to vaccine planning, and I've asked Joe Prado, who is really overseeing our vaccine planning, to join us, and hopefully he can join us at least for a little while to help lay out what our vision is for getting vaccines out to all of the different populations that we need to vaccinate as quickly as possible. And then we'll end with some good news as well about monoclonal antibodies. So just in terms of numbers, here's where we are in Fresno. We are just over 65,000 cases. This is a pretty unprecedented surge, and we're continuing to get just many hundreds of new cases every day. It's really challenging our contact tracing efforts. So one takeaway from that is please just give good instructions to the patients that you're testing. I know many of you are doing that, but just be extra mindful about spending that extra 90 seconds and really letting people know that even if the health department doesn't call them, if they're symptomatic, if they're around people who are symptomatic, they absolutely need to be careful, wear a mask at all times. If they have people that they live with within the house, especially if those people are vulnerable, they really need to try to isolate as much as possible, because household spread is one very unfortunate way that transmission is spreading very, very rapidly. And whatever we can do to help protect, especially the elderly and those with comorbid conditions, even within households, people should be wearing masks. And even within households, people need to be keeping their own space. I know not everybody has their own bedroom that they can retire to. That's really one of the great challenges of this pandemic, is that the populations that are hit hardest are the ones that are already faced with a lot of overcrowding in their housing situation, in their work situation, et cetera. Please take that extra time to explain this to people so that they can make good choices about what they're doing. And then obviously the low-hanging fruit is don't go to gatherings, don't go to any inessential errands, and really stay home as much as possible, especially while they're symptomatic. Even if they're asymptomatic, we know that there's a lot of people that are just spreading and not even knowing that they're symptomatic. And people just need to get the message, I think, at the time that they get swabbed, because we may not be able to catch up to them at the rate that things are going. In terms of the number of deaths, that's another very tragic aspect of where we are. The number of deaths currently reported is 646. But we've already had several more dozen deaths since then, and the number is probably closer to 800 at this point. Just seeing the death certificates that are still pending, and that really is causing so many bodies to accumulate that it's really impacting where we can put the bodies. As grim as that is, that's the reality. We're working with the coroner. I think Dan Lynch is actually on calls pretty much all afternoon, trying to figure out solutions for what to do with the number of bodies that are just kind of accumulating in the various different hospitals, morgues, funeral homes, et cetera. So that I never thought that we would get to this place, but here we are. And I think everyone needs to know, with as much sensitivity to the families as possible. I mean, with everything else that's going on, this is just one more, I think, added insult that we're not even able to dispose of the decadence in as dignified a manner as we would like.
Hey, Dr. Vohra, this is Dan.
Here's where the California curves are. I mentioned this just because the whole state is experiencing what we're experiencing. In some ways, LA is even worse, although I think we will be there, where they really don't even have space for ambulances to drop off patients. There's just some really nightmare scenarios going on in Los Angeles. They're having to clear out the chapel and the gift shops in some of these hospitals just to put patients. And the reason that impacts us is because, everyone's kind of competing for those same resources from the state. So if you can imagine that whenever we ask for extra staffing resources or extra supplies, many other counties are also asking for those same supplies and staffing. And so that just makes it that much harder to really fulfill those requests. But unfortunately, the whole state of California is just in this wintertime surge that it's somewhat mysterious exactly what's driving it. We know that it's related to gatherings, it's related to indoor activity when people may or may not be masked up. It may actually be related to this new strain, which seems to be more contagious. Although it hasn't been documented in California, I won't at all be surprised whenever they say we found this new strain. It seems to have started in Europe or the UK, but they found it in a lot of other countries by now, like France and Canada. It's just a matter of time before it comes to California. I believe the first case of this new strain was reported in Colorado. So it's really knocking on the door of California's backyard. And, it's just a matter of time before they start reporting this new, more contagious strain here in California. And that might explain some of the surge that we're seeing. I don't think it explains everything, but it might explain some of the surge that we're seeing. This is what our hospitals are looking like. Again, very impacted. The data that I pulled today shows 629 hospitalized patients with 7 ICU beds available. Regionally, we have 0% ICU capacity, and it's been like that for several weeks in the San Joaquin Valley. The hospitals that we're talking to are holding ICU patients outside of the ICU in the emergency department. They're over capacity in many respects. I don't think that that's news to anyone who's working in these hospitals, but that really is what the data is showing as well. And you can just sort of see here, this was the summer surge just right at the end of July, and the winter surge that we're experiencing now is really just double that. So this is unprecedented in terms of what we're experiencing in the healthcare system.
Dr. Vohra?
Yes.
We don't see your slides.
Oh, you can't see my slides.
We see you.
Sorry, I forgot that little extra step of sharing my screen. Let me find that button. Thank you for being brave enough to speak up. Okay, there you go. Can you see that?
Yes.
Okay. Do you see all the numbers and the curves and stuff? Just kidding. It's a
one slide.
Okay. All right. So here, I'll just move on. Sorry, I'm just being probably too goofy for the mood today. But let's just move on. Hopefully, I'll send out these slides. I don't think you missed very much. I was just showing the curves. And like I said, this was the hospital curve, 629 hospitalized patients, 7 available ICU beds. This was just a placeholder. Just moving into I really wanted to talk about the surge AFL first. So let me skip around, and I apologize. But basically, earlier this week, over the weekend and then on Monday, some things have happened, and I think that it makes sense to talk about those in the context of this surge. So first, the Porterville site has become more active. They've actually got 10 beds that are active, but they've been able to discharge approximately 20 patients. So they are scaling up, and they are moving through and helping with decanting these patients from the acute care facilities, and that's great. Please continue to use them. Here are the inclusion-exclusion criteria from the Porterville Alternative Care Site, also known as PACS. They are looking for convalescent COVID patients that need minimal nursing or medical supervision. And please continue to work with them. They are getting patients from almost all counties, all the way from Merced down to Kern. And so it is kind of a nice facility for us to be able to send patients to. In addition, we've still got the overflow area at CRMC, and that's over at the North Medical Plaza. They've really made some very nice conversions of some office space. And that's really, again, a county resource. It's expected that all hospitals from the county can send patients there, and you can contact the transfer center in order to get the criteria. The big difference between Porterville and the North Medical Plaza is that the North Medical Plaza is for COVID negative patients, and so they will require that extra inclusion. But again, it's for low supervision, low oversight patients. They can do some higher level of care, I think, than Porterville. I think they're working on trying to get patients that can actually receive dialysis, which would be nice. And although that's not live yet, those are the kinds of issues that these sites are dealing with, is they are trying to serve as best as they can. But, you know, whenever patients are more complicated, then they really have to troubleshoot and make sure that they are getting everything arranged for all of those patients' medical care needs. The plan is, you know, once the North Medical Plaza starts to get filled up, then we are going to go ahead and open up the Fresno Convention Center with the staffing, the contracted staffing company that's currently at the North Medical Plaza. They're basically gathered at this point, and they're doing pretty well. But you know, it'll present an additional challenge if we need to kind of split them in two, and then keep the North Medical Plaza open potentially at the same time as we open up the convention center. But that's where we may need to go. At 3:30 today, I'm actually having a conversation with a team from Canada that doesn't supply people, but they do supply monitors and oxygen concentrators so that we can open up critical care spaces in non-traditional areas. So those are the kinds of conversations that we're having. And this is all part and parcel of this, you know, crisis care framework that we're now pretty much in, but there's some formalities that the state wants us to fulfill in order to actually transition into this crisis care. Which brings me to the AFL that was released on Monday. This is the AFL 20-91, the Crisis Care Continuum Guidelines AFL. And basically, the AFL refers to a couple of different links that you can find at the bottom right of this slide. One is a checklist that I'll show you in a couple of slides. And the other one is a big 40-page packet that really walks hospitals and healthcare systems through all of the things that they need to think about and solutions that they can try to work on whenever they are forced to kind of transition from, you know, definitely from conventional to contingency, but then from contingency to crisis care. Just to flesh out a little bit more about what this AFL says, basically the goals of the healthcare delivery system in California should be to remain in conventional or contingent care as long as possible, but to prepare plans for crisis care as a last resort. Work with other facilities, really other coalitions, public health departments, and then the operational area coordinators, and really just try to build as strong a network as possible, with the understanding that even if one facility isn't able to match the demands on that facility, if we have a tight network, that we can all work together and hopefully really fulfill any needs that arise as a result of our collective efforts. And really share these plans with the public so that people have a clear and transparent understanding about what this continuum means and what their expectations can be whenever they enter the hospital. And I think that that's the reason why I wanted to bring it up on this call, is because I think all of us on this call really do have that duty and obligation to educate our patients, educate our communities about what this actually means, because things are not normal at the hospitals, and people need to understand that. And people need to adapt and be a little bit flexible, because the hospitals are having to make these really hard choices about the kinds of care that's being delivered. I think one schematic that really helps to put this all in perspective is to really divide up the types of care into 4 different domains, the types of resources. So there's resources related to space, resources related to staffing, resources related to supplies, and resources related to the actual delivery and level of care. And whenever you have conventional care, basically it just means that you know, things are kind of humming along, but not straining the system too much. Whenever you move into contingency care, which it could be argued that we've been in throughout this pandemic, but you know, whenever you move from conventional to contingency care, it means that you're using different spaces such as pre-op beds or PACU beds. You're opening up from single to double allocations in some spaces. You're asking staff to kind of adjust their schedules, work longer shifts, maybe shorten their vacations, and then obviously bringing people back from quarantine a little bit earlier is one other aspect of the contingency care that was introduced a little bit more recently per the CDC recommendations. And then with supplies, again, this is what we've been struggling with, I think, throughout this pandemic is, how do we reuse limited supplies that we may not be able to replace? How do we adapt and substitute, knowing that we may run out, at a very inopportune time? And then the level of care is functionally equivalent, but it may be delayed. And that's the kind of thing where, whenever we postpone elective surgeries, for example, or whenever we do workups as an outpatient instead of an inpatient, just to help save that extra bed. Those are the kinds of things that we're talking about with the delivery of the level of care. It's functionally equivalent, but it may be delayed. That I think is the big difference between contingency and crisis, is that things become so strained that you basically have to deliver perhaps a different level of care, and you really have to make these decisions about triaging and allocating either supplies or staff or space related to whatever is happening on the ground. This is meant to be a continuum. It's not meant to be a switch that you flip and then it's irreversible. It's meant to, by design, there's going to be some things that move forward while other things move backward. Staff might come back when you lose beds. You might get beds when you don't have staff. That's just part and parcel of what a disaster looks like, and that's understandable. I think what this helps to do is by communicating this framework to our peers, our staff, our patients, and our community, we're really just owning the fact that we are in the middle of a disaster and that things are not going to look normal. That if they expect to have conventional or even contingency care whenever really the level of resources that we can offer is the crisis level, then there's going to be some disconnect. And we're just trying to, I think, mitigate that dissonance that people might feel, either within the healthcare system, which we know whenever people have to make decisions on the fly, these are really hard choices where there's no easy answers. That can be pretty psychologically difficult and frankly hard to do whenever you're really invested in a patient's case. And so another thing that the state is really frankly requiring is that we set up committees and even triage officers that can help make some of these hard decisions who are not directly involved in patient care. So there's a lot to this. I mean, like I said, there's a 40-page packet from the state. There's hundreds of other pages that you can look at when you talk about crisis care standards and what crisis care guidelines actually look like. All of the hospitals in our county have been working towards, what's going to happen whenever they enter or have to transition to more crisis level of care. And we've been talking in dialogue with them for many months about, the kinds of adjustments that would need to be made. But I think it's time to really, not just talk about this as a theoretical construct, but something that we may actually have to invoke and enter into very quickly. In terms of the checklist, I think that this pre-implementation checklist is good. This is basically telling hospitals and healthcare facilities, make sure you've thought about all of these items before you declare that you're in crisis or move into crisis, and really write up a plan about how you've addressed all of this. So that those plans are being written right now. They'll be submitted to the state and possibly posted sometime. And so all of that is going on kind of behind the scenes at the level of these crisis care committees that have been formed, and at the level of the hospitals talking to one another and talking to us at the county level. And then we also invite the state to sit in on those dialogues, and we've been having them almost continuously for the last week or so. So that's kind of where things are. I know that this doesn't apply to every single person in your clinical practice directly, but you have to understand that, if as a member of our community, certainly, but also as someone who may need to use the hospital to send your patients, these are the kinds of conversations you want to have. Obviously, there's a lot of issues related to end-of-life conversations and life-sustaining orders and things like that you'll also want to be thinking about with patients as appropriate. Those are, as an emergency physician, those are never easy to have in the emergency department, as you can imagine. So we really appreciate whenever our colleagues in primary care and our colleagues that know these patients a little bit more longitudinally have had the chance to have those conversations. But you know, we're all in this together, and I think that these are good resources. And so I've just included the links for the memo, which is the AFL, as well as these checklists, and then the larger packet from the state. And if you have any questions or need resources, then definitely reach out. The one thing that I'll include in the slide set is a website called Vital Talk. And Vital Talk is a website, I believe it originated in Washington State, but it's basically set up by folks that do these end-of-life conversations and have these really hard conversations all the time, and they're really good at it. And they basically have set up a website to help teach other people how to do this efficiently, humanely, and in a way that's appropriate for crisis level standards of care. And so I'll include a link to that website, because you'll find that useful if you just need a refresher about how to have these conversations, and especially related to COVID, some of the most common sort of conversations that end-of-life doctors are having related to coronavirus infection patients.
So I have my cold shower.
Okay, a little bit of happy news. This is from our colleagues at St. Agnes. This is something that we've been working on at the health department for a little while as well. And this has to do with those monoclonal antibodies. So as you know, that there's two different products. There's one called bamlanivimab, and another one which is a combination of this casirivimab and imdevimab. And that's a cocktail that's made by the Regeneron company. Very happy to report that St. Agnes is starting to do these infusions. And here's a number for you to contact the infusion center, see if your patient might qualify. And hopefully some of my colleagues from St. Agnes can have a chance to talk about this program. We're also working with several other clinics and sites to make sure that St. Agnes isn't the only place that's offering this, because you know that would be, I think that would pretty much overwhelm that facility. Dr. Bautista has very generously stepped up, and he and his colleagues are also going to start offering this infusion. Here's their office number. So those are live and pretty much ready to go from my understanding. There's a few others that are going to come online, hopefully just right after the year turns over. And that will be basically several nursing homes have stepped up to offer themselves as sites where these infusions can be done. And one of our specialty clinics in the nephrology space is also trying to work on not only offering these infusions for their patients, but also for the larger population. So that's kind of the crux of this is, in general, nationwide, these antibodies are being offered for free by these companies, but they're being underutilized. That is a national kind of trend that's being noted. And there's several barriers that are leading to this underutilization. The most important one seems to be that you know, these COVID positive patients need to be put somewhere where they're not going to contaminate and pass the COVID on to other people. And so you really have to have a space that's designed to do that. In addition, it takes several hours to do the infusion, so it does require some, I think, investment of nursing resources and space allocation, which is very short right now, especially at our hospitals. And thirdly, there's just an education gap. I mean, this is a really new product. A lot of physicians and patients don't know about it. And then the selection criteria are a little bit narrow, because you have to have someone who is COVID positive, but has not had symptoms for longer than 10 days and has some age criteria as well as comorbidities. So those are the kinds of inclusion criteria that they're looking for. In general, these monoclonal antibodies are not exactly flying off the shelf, which is what people expected. And so we are really trying to troubleshoot why that's not happening here locally in Fresno County. I'm so glad to see that St. Agnes has taken the initiative to start doing this. I'm really hoping that we have more sites that are offering to do this. Here's more information, including a nice video about how to mix these medications. So another barrier, which I forgot to mention, is that there's a general, I think, perception that you have to have a relationship with a compounding pharmacy who can mix these medications and then send them to you. And we did a deep dive into that, and that's actually not required. Any doctor's office, any clinic can actually mix these medications. Obviously, any hospital can mix them just through your pharmacy. and you don't actually need to go through a compounding pharmacy. Having said that, there are several compounding pharmacies in town that will work with you or your clinic to get this infusion done. And you could just set up a relationship with them. And then basically the way that this allocation program works, we will actually be delivering the medication to the compounding pharmacies. And then a physician can just order this medication, and it'll be mixed and delivered for your patient to come in and get this infusion, wait a couple of hours to just basically as an observational period, and then be discharged. The understanding is that these people have to be stable enough to not require hospitalization or oxygen. Like, they really have to be walkie-talkie ambulatory in order to qualify for these antibodies. And here's this slide has some more indications for the bamlanivimab product. They're basically identical, very similar for the other product as well, which is made by Regeneron. So I think that that's some happy news. We're not done yet. We're not giving up on finding more sites. But I just want to say kudos to St. Agnes and to Dr. Bautista for stepping up and really leading the charge in our county. I know that other hospitals are working on this and trying to troubleshoot how they can offer it as well. And I know that even nursing facilities are trying to offer this, not only for the skilled nursing facility residents, which are obviously a very high-risk population, but also anyone that can come and get this infusion and then get discharged again. And that would be really cool if we could use our skilled nursing facilities for that purpose. But we want to make sure that it's done safely and that it's done appropriately. So we're going to keep doing some homework on our end, and hopefully we'll have some good news about even more sites offering these antibody infusions as early as next week. All right, 2020 is almost over. I guess that's the third piece of good news. I hope everybody has a good end of the year. And I don't know if Joe Prado's on, and if you, Joe, are you on? Are you able to come on and talk about vaccines? Or do you want me to just kind of introduce where we are with vaccines and
Okay, can you hear me okay, Dr. Vohra?
Yeah, hey, how's it going? Yeah, we sure can.
Okay, awesome, great. No, I'll go ahead and start with a generic presentation and just take some questions as well. So as of today, we've received about 32,000 doses, and we've redistributed about 53% of those doses. And the big focus has been with the hospitals at this time. But we've also, this week, we started getting into some primary care physician offices. We got into our federally qualified health centers, a particular specialty clinic provider. These are individuals in their COVID-ready enrollment, and their communication to us express interest in assisting us in actually vaccinating the general population as well. So not just vaccinating their staff, they offer to vaccinate their other medical groups, also our assisted living centers and all these other populations as well. So we've actually started giving vaccine to them as well as of this week. You know, for all providers, I think what's really important right now is if you are interested in receiving vaccine, and let's say just for your staff, for yourselves, but also for in the future for your population, for your patients, please go through our website and go through COVID-ready enrollment. That's going to be really key. And the reason why we want you to be enrolled is because once you're enrolled, what you're saying is you meet the storage requirements, and we can have vaccines shipped to you directly. So that is a significant plus, not only in our operation, but in yours as well. You don't have to wait for vaccine for delivery or pickup from the health department. You can actually receive that directly. Now, with a direct shipment with Pfizer, the limit is 975. So if you don't meet that threshold of 975, you couldn't receive a direct shipment. And again, Pfizer, just a reminder, that is ultra cold. If you don't have that storage capability, we wouldn't ship that out to you. But if you do have the refrigeration capacity or the regular freezer capacity that Moderna requires, then we could actually ship that in increments of 100 to your office. And so that is why it's really important to be a COVID vaccine provider going through that process, is then we can really get into direct shipments. Let's say, for instance, you evaluate those requirements today and your office doesn't meet the requirements today. Please don't stop there. Communicate with our COVID enrollment email box, and Sim will provide that to everyone here. and just let them know that you don't meet the requirements today, but you're interested in meeting those requirements in the future. For instance, purchasing a refrigerator to be able to store the vaccine, a freezer, whatever your situation may be. What we want to do, though, is actually get you vaccine if you're willing to vaccinate your own staff. So, so that's going to look a little different if you're not a COVID, if you're not enrolled in COVID Ready. What we'll have to do then is we have a local system that we will introduce you to, where you would basically upload all your employees' information into, and then we would handle the care integration reporting. You would just basically work in the local data system to meet those requirements. The downside to this type of workflow is the vaccine we provide to you is on a daily basis only. Since you're not approved through the COVID Ready, we can't leave vaccine with you overnight. We would basically be going out, delivering vaccine to you, or you're picking up vaccine downtown, and you can only have that vaccine for that day, and you would hopefully use all that vaccine up, but we would have to do a daily type of visit to your facility. So there's two workflows we're trying to develop so all providers can participate. But if you don't meet those requirements today, we really want you to evaluate those and see what you can do to become a full-fledged COVID vaccine provider. So when we do have vaccination for the general population come April, come May of this year, we want to have as many doors available to our community to go in to get vaccinated. So that's why if you don't have that, meet those requirements today, please work towards meeting those requirements. And for instance, if there is a financial barrier of a refrigerator or some other barrier, an EMR interface, let our COVID enrollment team know that. We want to be made aware of it. I can't say that we'll be able to meet that, address that issue immediately, but we definitely want to be able to capture that information and see if that is something within the funding resources to be able to remove that barrier. Especially if you're in a rural area and you're in a vulnerable population area, we want to be able to know about that and see if we can mitigate those issues there. So that's on the COVID Ready enrollment side of it. You know, there is it's a bit of a cumbersome process. We've been hearing about some providers being denied, and so they have reached out to us, and so we started to engage with the state on what the purpose, the reason for the denials. Their training is filling up here quickly. So we want you to go through that process. But, you know, I'd like to invite Richard Limbo to kind of speak a little bit on his experience on going through the COVID Ready enrollment and just give you a little more insight on what that looked like through a provider lens. Richard?
Hi, Joe. Thank you. Hi, Dr. Vohra. How are you?
Hey, good. How are you, Richard?
Good. So we were fortunate enough to go through the process, and we completed and were approved through the state system. And I can't tell you, first of all, I can't tell you how helpful people like Nicole have been and everybody else in the office. They really helped us through this. We got approved site visit yesterday, and we actually took delivery this morning. And ultimately, have vaccinated 75 staff members already today after we thawed. So it really was great. By the way, the sheriff deputies who escorted us, that was actually really cool, just from a vibe standpoint. But nonetheless, if there are any providers out there that are in the middle of doing the application and becoming a full-fledged COVID vaccinator like we are, we'd be happy to help you. You can come, we had one office come over today and look at our cold chain and our refrigerator and freezers and our units that we're using to monitor temperatures, our data log book. And I have a generic packet that we made for the patients that has a screening and consent form, the CDC form, the study and the use of the VAERS app from the CDC to report adverse reactions. So I have the whole packet. I'd be happy to share it with whoever wants it in PDF. You're more than welcome to use it. It really wasn't as awful as you would think.
Well, Jeremy, you just got yourself listed as a speaker for our webinar that we're going to make It's going to be called COVID Vaccination 101. It's in partnership with the Fresno Madera Medical Society. And you're going to be in our panel of speakers now that you've stepped up as someone who can help us walk
My
through
pleasure.
this.
I'll clean up the speech and I'll save the chin too. So that's nice for them.
Well, thank you. I'm just
Apologize.
confused. I wanted Joe to clarify, like, COVID ready versus CARE versus CalVax. I mean, it's just like, it's just this soup of different databases and registries.
Yeah,
It is.
It is. So COVID Ready is the enrollment process. And I'm going to confuse it even more. This is the enrollment process as of today. This will change as of January 11th. But as of today, COVID Ready is the enrollment process to actually bring all the providers in. That is where you sign your agreement that you're going to meet those cold chain requirements. You have those storage requirements. Then once you get approved into COVID Ready, there is something that some of you may be familiar with already, the California Immunization Registry System, we refer to as CARE. That is where all the patient information is going to go into. So what happens is when you enroll as a COVID Ready provider, if you're not into CARE system already as a provider, and some of you may already be, if you do Vaccines for Children program, you're already in the CARE system. That is a legal requirement already. So you may have already met some of those requirements. But if you are a COVID Ready enrolled provider and you're not in CARE, they automatically set you up in CARE as well. So there is a requirement once you actually provide the vaccine, within 24 hours, you're updating the CARE system with the patient information, the lot number, and all that other information that's required within 24 hours of administering the vaccine. And so if you have an EMR, you would want your IT folks to get in communication with the state folks to get that automatic EMR transfer into CARE as you guys are doing your normal daily business. That's going to be really key. Those are those two pieces. You'll hear of CalVax. CalVax today is our inventory management. That is what the county looks. That is where we get to see all the approved providers on our list. That is a system we use to actually do direct shipments to you, and we actually authorize it. And so this is where you actually request for vaccine, and then we authorize the actual amount there. CalVax, as of January 11th, is going to take over COVID Ready. So COVID Ready was just to get us through December and January, and CalVax will be the new enrollment mechanism there. And so what we're trying to find out right now is COVID Ready was only for people that met those storage requirements. We know in our community, we will have workflows, we will have providers that don't meet those requirements. That is why we're creating a local system to be able to keep those providers providing vaccine, but it's through a local system there. And so, so that's a little bit of the nice confusing data systems that are involved, but definitely on January 11th, when CalVax right now is planned to take over COVID Ready, pretty much the website will be there. Instead of doing a COVID Ready application, you're going to do a CalVax application if you wait till January 11th.
Joe, I would assume that anybody that's in the COVID Ready now will automatically be grandfathered and moved into that CalVax.
Correct. Yeah, you keep all your credentials and they'll migrate you over to CalVax.
Okay. And CARES wasn't as awful as everyone thinks. The biggest thing was to be able to meet the cold chain. And then the site visit from the county was great because that was actually a learning tool as much as it was a inspection, for lack of a better phrase.
Thank you so much, Rick.
No, my pleasure. Thank you guys. I'll let you know how the input of the data today, because that'll be probably what I'm doing till tonight. God knows how long.
Yeah, I would say, you know, one key takeaway from every one of these vaccination experiences that I've seen is pre-registration.
Absolutely.
You don't do on-site registration. You really want to have your people appointed and ready to go. They just walk in, get their shot, wait 15 minutes, sometimes 30 minutes if they have a history of allergy, and then walk out. If you start having on-site registration on the day of, it's really going to ball you up. And so please don't even plan on that. I would say just from the get-go, you want to have pre-registration.
And what we did is, that's just that we dispersed packets to the employees that elected the vaccine. They were pre-registered. They were pre-screened. it was reviewed twice. We knew if they had a history of anaphylaxis or not. Came in, vaccine, then we had what we call a cool down room available for them for 15 minutes or 30, and then they went back to work. So it's actually not a workflow, and I'd be happy to share it. Anybody's welcome to come over and see it. That's completely fine. There was a IQ Vision Center, their operations technology people came over and saw it. It was a little bit of a visual learning for them, pardon the pun, but it was great.
Thank you, Rick. So I'll just go into the tiers of where we're at physically right now. So pretty much we've been able to provide the hospitals with their first dose of vaccine for their staffing. And not only their highest risk staffing, we're actually able to provide above the high risk staffing as well. So we're really moving in along tier 1, moving into tier 2 as well with the hospitals at this time. So next, as you heard, this week we did EMTs. That went really well. American Ambulance assisted with really managing that complete points of dispensing site. They did the vaccinations themselves. Our staff were on site. Because they're not a COVID-ready enrolled provider, our staff are pretty much on site the entire time, ensuring cold chain control is maintained. Any type of insight they can provide to the team as well. So that's kind of how the EMT closed point of dispensing site has been thus far. So we hope to be able to partner with them again in 28 days for Moderna vaccine for their second dose and be able to keep those doses ready for them and for their second dose there as well. Something really important that we noticed with the EMT clinic was that, you know, if your employees, definitely in whatever mode you're in, if they say yes to a vaccine, let's make sure they really truly are yes, because it really becomes a challenge to try to fill people in for vaccine that day of people dropping out per se. So, you know, if you're going to do something within your offices, make sure you survey people and it's a true yes as a versus maybe I think I want the vaccine that day. We're learning more every day from the state on each of these vaccines and how it can be handled. And so we just want to make sure whenever we deliver vaccine that you, if you ask for 100 doses, you will use 100 doses that day. So it wouldn't hurt to have a little contingency built into that if you do have people who drop out that particular day. But that is just something that we're learning on a daily basis, some new requirements that are popping up through the state as well. And we'll communicate those out as you become an enrolled provider as well. So as we work on the tier 1 here, we really look towards being complete with tier 1 by the week of January 11th. And so next week, we're working on the inpatient psychiatric facilities. We'll be moving into the jail medical staffing components, and we're hoping to find our partners for the dialysis centers. We found a really good provider that is willing to assist to vaccinate those centers. They had unfortunately, their application denied initially, and so we're reaching out to the state to get that cleared up so we can mobilize them here shortly. And so we'll have vaccine available for the tier 1 first dose easily and look towards being complete by the week of January 11th. Tier 2, we are already dipping into tier 2. As I mentioned earlier, the federally qualified health centers, some of those urgent care clinics, we have a COVID-ready improved on an urgent care clinic as well. Intermediate care facilities. You know, what's new this week is we're gaining new knowledge of the federal pharmacy program for skilled nursing facilities that has been in effect. This week, they've been out in our community doing vaccinations. There is that was part A. There is a part B for assisted living facilities. And so that they're looking at getting that onboarded in the next couple of weeks. We did get a list. There's about 50 facilities between long-term care facilities, assisted living facilities that didn't enroll. So we're going to actually contact those 50 facilities and work with our clinical resources to be able to vaccinate those providers there. And so as we move forward with the assisted living facilities, we want to be able to get those completed as well by the week of January 11th. And so on the screen there, you see this is a significant resource to our community here. Having this pharmacy partnership has been really good because we're really trying to build up our distribution here locally So having these facilities managed and assisted by the federal resource has been a great partnership, and really do appreciate that. And so what does that mean? That means here locally, we need as many as you enrolled in COVID Ready, enrolled to be able to do vaccine distribution, because we don't have a lot of approved providers. As of this morning, I looked in the queue, we only have about 40 medical providers, clinic sites that are approved to be COVID vaccinators. We want that number to increase in the hundreds. And again, that is all with the goal of providing access to our community. By the time we get to general population, there's multiple sites ready to do that. So that is something that I'd like for you to really evaluate in your systems. And if you are a vaccine for children provider, you've already met the storage requirements, then you just evaluate, you can store COVID vaccine. You just, in the same refrigerator with VFC vaccine, you just need to clearly mark it, have it in a different area, clearly delineated. Of course, that is not a lot of storage capacity for using an existing refrigerator, but that's just an idea if you do want to be able to get in early on the vaccination and you are a VFC provider.
Yeah, and I would say even though the cold chain is complicated, I mean, this needs to go the way of testing. You know, as we've said before, if you tested for influenza, you need to be able to test for COVID. If you gave flu shots, you need to be able to give COVID shots. And that's really where we need to go with this. It really just has to get scaled up, and we need to have all hands on deck in order to really be able to vaccinate all the people that we need to vaccinate.
Totally agree, Dr. Vohra. And as we go into tier 3, specialty clinics, labs, dental offices, and pharmacy staff, we're looking towards February, March. And, you know, and that's a planning month, right? That tier 3, we can dip into that sooner. In reality, we want to make sure as we see the vaccine doses come in, that that's realistic. And as of right now, we did get notice last night, our second doses are coming in for the hospitals this next week. So we have no indication at this time that there will be a holdup in the supply chain. So we need to push forward to tier 3. And so we want to be able to hit tier 3 providers roughly in February and March. You know, you're seeing some other pieces here in ACIP's recommendations and moving essential workers, moving age groups up into the upper tiers. We're still waiting for the state allocation table to see what that looks like. You know, our whole focus is to make sure our medical community is ready to give the vaccines. So we want to make sure our medical community is vaccinated as we start giving vaccines for the general population, whether it's 75 plus or the essential workers. We want to make sure we have a healthy medical community to be able to do that. So the numbers are going to get bigger. As you can see on the screen right now, you know, remember healthcare workers were about 58,000 in Fresno County. But as soon as we start getting into essential workers, this number is just going to go extremely large for our community in our state. You can see that here, some statewide numbers here. So we're going to need all of you ready to be able to assist your patients and that meet that particular criteria there. And so, you know, we really see those essential workforce depending on vaccine supply. That really, we can see that going into March, April, getting into some of the essential workers as well. So, of course, that's contingent upon some other pieces. But if somebody starts, if they ask essential workers, when does that look like? For now, we would say March, April. But if we are able to improve our distribution system and look at the vaccine supply coming in, and we're able to move into essential workers sooner, we will absolutely do that. Just today, we don't have that distribution system created enough. We don't have enough vaccinators to really dip into essential workers. And honestly, we don't have enough vaccine to get there yet either as well. So Dr. Vohra, those are some of the key points I wanted to bring up with the group here. Anything else you think we should hit on? Or
there's a couple of chat questions. I don't know if you're looking in the chat. If you only want vaccine for your staff, do you still need to enroll in COVID Ready?
You know, you don't. Just go to COVID enrollment email box, request that you are strictly looking for vaccine for your staff and you're willing to administer the vaccine. We will set you up with our local data system to be able to do that and assess a delivery date to get you vaccine.
Okay. And then what is the typical timeline from submission via CalReady and approval you know what the turnaround time is?
So COVID ready, I'm assuming not Cal ready, but COVID ready. You know, Rick could probably speak to his timeline. What I'm hearing today is roughly anywhere from 10 to 20 days.
For us,
Okay.
it was just under 10 days with the holiday.
What do you do with leftover doses?
Never. We don't want to hear leftover doses. Find somebody in your community, in your office. To
Go stab a stranger.
Yeah, seriously, like somebody's walking out in the front door. The goal is once we hand you the vaccine, you know, that is your asset to manage, take care of your workforce, take care of the people that have said yes, but we really want you to vaccinate as many people as possible. So when you actually sign up, we're going to ask for how many office staff you have and, you know, high risk, just to get a sense of how much allocation we give you. But if somebody changes their mind, find somebody else to give the vaccine dose to. So we don't want it back. Let's just say that.
And I thought I'd speak up. I wrote this in the comments. This is Dr. Kelly Hughes. I'm with Omni Family Health, and we have COVID vaccine at our Kern County sites. We've been approved through COVID Ready for probably at least a week for our Fresno sites. We've got 3 sites approved. So we are fully prepared for all the stages and all of that. So
Great.
contact me.
Will do, Kelly. Will do. Thank you.
Thanks.
Yeah, thank you. And same thing with Rick. Let's get your packet out. It seems like there's a lot of demand to look at it. So if you want to send it to us, Rick, we can distribute it. We're creating stuff. You know, obviously we're creating stuff here. We've got the website that's already ready for medical providers. It's right here. I put it in the chat as well. We're working on a webinar. We're working on like a 1-pager or a 2-page tip sheet that really answers these questions. You know, what if I just want the vaccine for myself and the staff? What if I want to become a provider? What if I don't really want to become a provider, but I can just show up and help administer vaccines? I think that there's some use to that as well. So I think we just need to tailor, you know, many different models for delivering vaccines, because people are going to have different needs and different commitments that they want to make. And we really want to make this work. But right now we're definitely looking for help and assistance. So thank you for reaching out for those who already have. And if you haven't yet, then please consider stepping up.
Yeah, and
Dr. Vohra, oh.
As we learn more about the new state system that's going to be going live January 11th, you know, there's some assumptions we're making that it won't take care of, it won't address all of our potential workflows in Fresno County. So we just may, we'll just make a decision on whether or not we put you through the local data system, or you'll be a full-fledged CalVax provider.
So do you want people just to wait till January 11th? And then
No, get them in the queue already. I want them communicating with our staff. And then our staff, once you determine whether or not you do meet the requirements, our staff will just keep a listing, and we'll start building your profiles in our local data system.
these required trainings, can people start doing those even before they're approved officially, or how does that work?
You know, when you click on those required trainings, you know, those are usually by appointments, and they scheduling, and they were full the last time we looked into it, but they are adding new trainings. They are adding more resources to that. So those are actually required before you even accept vaccine, and they truly accept you being approved. Your application could stay pending if you don't do those trainings.
Okay. Any other questions?
Dr. Vohra, this is Dr. Lynchhead. I was just going to say, I'm working with a team that's helping on the vaccine side too, and we're going to create an email very soon here just for COVID vaccine questions. So for other providers, just stay tuned on our keep checking the website, and maybe hopefully by next week we'll have that in that email specific for COVID vaccines that we'll be working on.
Great, thank you so much. All right, any other questions for the team? This is great. Thank you all so much. I know you've been working in a frenzied pace, and our work is yet to be done, but we really appreciate you spending time and explaining all of this, Joe and Rick. And we appreciate everyone's questions too. We know that there's a lot of curiosity about what comes next, and we're hoping to share this roadmap as fully as we can. Any other questions? All right, well, we are at the hour, so I think we'll adjourn there. I'll share out these slides and keep the questions coming, and have a happy new year. Hope that you get to rest a little bit more this week, and hang in there. 2020 is almost over, and 2021 will definitely be better. So thank you so much.